Hi everyone, my name is Stockwell. I'm a researcher at RAND Europe, which is a non-profit research organisation based in Cambridge. We've also got offices in the Netherlands and in Brussels. I'm here today to represent the Science Rapid Evaluation Centre. I'm not Sarah, and I found out on the train that I needed to do this today, so apologies, and I'm going to be mostly reading her notes. So, adopting tech-enabled remote monitoring in the NHS and generating evidence that is fit for purpose. So technology-enabled remote monitoring has become a central part of discussions about the future of NHS care delivery. And by this we mean the use of digital technologies to collect, transmit and sometimes analyse patient data outside of conventional clinical settings in ways that support ongoing care and clinical decision-making over time. We've already had examples of this, but it can include patients on virtual wards, submitting observations through apps or telephone support systems, or people with heart failure transmitting physiological data to clinical teams at home. The attraction for the NHS is obvious. Technology-enabled remote monitoring promises earlier intervention, more proactive chronic disease management and care close to home, better patient experiences and potentially reduced pressure on overstretched services and more. But there is significant policy and operational momentum behind it, but there's also a persistent problem. Many remote monitoring initiatives show promise in pilot and then struggle to scale, spread and sustain in routine practice. So the question increasingly facing the NHS is not simply, does remote monitoring work? It is, what kinds of evidence help us to decide where, when and for whom, and under what circumstances should it be adopted? In terms of evaluation and bringing an academic perspective today, I'd like to argue that evidence for technology-enabled remote monitoring needs to move beyond narrow assessments of technical performance or short-term outcomes. Don't get me wrong, it's important, but the adoption decisions in the NHS are rarely determined by technology alone. They depend on how technologies interact with clinical workflows, workforce capacity, organisational priorities, patient capabilities, data infrastructures, and models of care. In other words, remote monitoring is fundamentally a socio-technical intervention. That perspective is reflected in the NAS framework, the non-adoption, abandonment, scale-up, spread and sustainability framework, which many in this room may know. The framework highlights that implementation success depends not only on the technology itself, but also on organisational readiness, the adopters involved, wider system factors, and the ability to adapt over time. This is important because many evaluations of remote monitoring have historically focused mainly on whether technologies work under controlled conditions, while paying less attention to how they function in real-world NHS settings. The challenge for evidence generation is therefore not simply establishing efficacy, it is generating evidence that supports real-world decision-making. From Sarah's perspective, we might think of it as traditional evaluation models are often poorly aligned with realities of digital innovation in healthcare. Randomised controlled trials remain important for some questions, particularly around safety and effectiveness, but they are often too slow and too fixed to keep up with the pace of rapidly evolving technologies and service delivery models. By the time findings emerge, the technology and the implementation context and even the policy landscape have changed. NHS organisations often need evidence within months, not years. And this is one reason why the rapid evaluation approaches are becoming increasingly important. NIHR now funds 5 dedicated rapid evaluation centres, including the SIDE, which is why I'm here today. The rapid evaluation is an intensive team-based approach designed to deliver actionable findings on programmes or innovations quickly. It is about producing responsive, relevant, methodologically robust and accountable and actionable evidence with useful timescales. Typically, this involves mixed methods evaluation approaches delivered over weeks or months rather than years. For the SIDE, one important principle is treating remote monitoring not simply as a technology product, but as a service model. The relevant unit of analysis is the wider pathway of care into which monitoring is introduced. That means evaluations need to examine not only devices or platforms, but also patient selection, escalation pathways, staffing, clinical governance, workflow integration and adaptation over time. This creates a strong case for mixed methods evaluation. Quantitative data are essential: admissions, readmissions, service utilisations, costs, mortality, patient-reported outcomes. But on their own, these findings rarely explain why the implementation succeeds in one setting and struggles in another. Qualitative methods are equally important for understanding the organisational and human dimensions of implementation. Examples come from rapid evaluations of our home monitoring service that we've conducted for COPD, heart failure and blood pressure monitoring, using interviews with industry, policy, clinicians, managers and patients, combined with observations of real-time use of remote monitoring and the work around it. These evaluations have all showed that success heavily depends on organisational integration rather than on the monitoring technologies alone. In some settings, clinicians describe monitoring dashboards generating large volumes of alerts without sufficient workforce capacity to respond effectively. Elsewhere, uncertainty emerged around responsibility for escalation of decisions between primary, community and secondary care teams and across the NHS and private providers. Patients often valued reassurance and continuity, but some also found monitoring burdensome or anxiety-provoking. Importantly, these services were constantly evolving. Eligibility criteria, escalation thresholds, staffing arrangements and workflows changed in response to operational pressures. Rapid qualitative evaluation allowed for those dynamics to be captured in real time, supporting adaptation and service improvement during implementation rather than years afterwards. Quantitative mixed methods for rapid evaluation are equally important. One example is the evaluation of COVID-19 oximetry at home pathways, which combined the analysis of routine operational data with qualitative implementation research. This was undertaken by one of the other rapid teams who explored outcomes such as emissions, escalation rates, mortality and healthcare utilisation. But the mixed methods design was critical because outcome data alone could not explain the substantial variation between sites. Some services achieved strong engagement and effective escalation processes, while others struggled with fragmented workflows, low uptakes, or difficulties integrating data into existing systems. Organisational readiness, staffing capacity, digital infrastructure, and local leadership all appeared to shape outcomes significantly. An important lesson was that context is not secondary to implementation, it is central to it. This all has important implications for how evidence should be generated in the NHS. First, evaluation needs to be embedded into implementation from the outset, not added retrospectively once the services are established. Second, evidence needs to extend beyond narrow activity measures to include workforce impact, patient experience, organisational consequences, equity and sustainability. Third, remote monitoring should be evaluated as part of a wider socio-technical system rather than as isolated technologies. Fourth, evidence generation approaches need to match the pace and the complexity of digital innovation itself. That means combining methodological rigour with approaches capable of producing timely and operationally relevant findings. Finally, evidence generation isn't sufficient. While independence and rigour are essential to evaluation, rapid or otherwise, relevance, responsiveness and relationships are also critical in ensuring translation of evidence into decision-making, into policy and practice. And we haven't mentioned, but it's a must, ensures equity and improves care for patients. Technology-enabled remote monitoring is unlikely to transform the NHS through technology alone. Its future depends on whether health systems can redesign pathways, develop sustainable workforce models, strengthen infrastructure and generate and act on evidence that genuinely supports informed adoption decisions in complex real-world settings. Rapid socio-technical evaluation approaches are therefore important and increasingly